Good morning. Welcome to Pediatric Grand Round. So I'll make two announcements before we get started with Dr. Kraft's introduction. Immediately following the Grand Round in the sixth floor conference room here, there'll be a roundtable discussion with Dr. Kraft. If any of you are available to join, if you stay on the line, you'll be part of the discussion through remote access as well. In addition, as a small token of Dr. Kraft coming back to talk to us, there is a book that if you would like to sign it, it'll be in the back of Blue Ridge Parkway, if you would like to do that. All right, Dr. Kraft truly needs no introduction, and welcome back home.
Thank you.
Dr. Kraft is the 2018 president of the American Academy of Pediatrics and comes to us with a background in primary care, pediatric medical education, and healthcare financing. She has deep roots in Virginia. She trained at Virginia Tech and went on to Virginia Commonwealth University for her medical and residency training, and also serves as the founding program director of the Carilion Virginia Tech Pediatric Residency Program. She has deep roots in advocacy for many years and serves as a Virginia Chapter AAP president from 2006 to 2008, where she is well known with the legislature on increasing payments for Medicaid services at that time. Dr. Kraft's work in early childhood and population health seeks to translate the goals of health equity into practice. AAP president, her focus will be on advancing child health through the practice of pediatrics. Please welcome Dr. Colleen Kraft.
Well, thank you, and thanks to everybody who showed up this morning. I'm really glad to see everyone here, and I'm going to be, okay, let me get modulated here.
You're good.
Okay, so I don't blow everything up here. Well, thanks for being here. We're going to talk a little bit about our 2018 Adventures in Child Health, and I have no disclosures. Talk about our learning objectives, looking at recognizing our emerging political, social, economic, and environmental factors that affect child health, and understand where these intersect with the American Academy of Pediatrics priorities. And then I'm going to ask everybody to commit to at least one advocacy activity in the next 6 months. And what you're going to find is that advocacy is part of your DNA. And this is not going to be hard to do. I'm just going to go through some of the ways that you're able to do this, because advocacy isn't necessarily going to the legislature. It's what you do for a patient. It's what you do to address some of the determinants of health that your patients have, and how you as an individual pediatrician and Carilion Clinic as an institution can help to do this is going to be important. So I'm going to start with where we're at in our basics, our blueprint for health. If you want to know where the Academy stands on any issue with the federal government, you can download the Blueprint for Health, which is a document that goes through what we know children need and where this needs to be shown in our Medicaid, Medicare services, SAMHSA, substance abuse, and USDA, what should food look like in schools, and what should WIC and SNAP look like. So it really goes through every department. And we talk about this as being our plan A without a plan B. And this is really important because in a very politically divisive setting that we're in the United States right now, the place where we shine is that we talk about kids. And what is it that kids need? And if you take any political stance, where do children come in? Because children are not the voice that's heard in any of these discussions. And as I go through this today, you'll see that. And you'll see where we as the Academy have said, okay, we've got to talk about this particular topic as it relates to children, our patients. So some of our successes, we did wind up getting 10 more years of CHIP, which is a Children's Health Insurance Program. In Virginia, this is FAMOUS, the Family Access to Medical Insurance Security. And this was really quite a big feat. The funding for CHIP ran out at the end of 2017, September. And we spent a lot of time advocating nationally and then statewide with our governors, because it's really the states that were saying, where's the money going to be for this if we put it in our budget? And just like like a lot of governments, they talk about legislation is a little bit like sausage making. You don't want to see how it happens. Let me tell you how CHIP happened and how we got it for 10 years. So we got the tax bill at the end of 2017. And as part of the tax bill, the individual mandate for the Affordable Care Act was taken away. Well, when the Congressional Budget Office looked at how are we going to fund the kids in CHIP, they did a financial modeling for using CHIP dollars to fund insurance versus using the healthcare exchanges to fund insurance. And without the individual mandate, the cost to put these kids in the exchanges went up dramatically. And so what they modeled was that 6 years of CHIP would be budget neutral. 10 years of CHIP would actually be a $6 billion savings. So that's actually how we got 10 years of CHIP. But, you know, at the end, we got it. The kids have it. We've got it for insurance there. Some of the other child health successes that have happened this year, and again, with all of the political divisiveness, it's really great to see what we have been able to do. The maternal infant early childhood home visiting was funded for 5 years. Any of you who use CHIP of Roanoke Valley to help out your patients, this is huge because this is part of what funds CHIP and really, really important stuff. The special diabetes care was funded for 2 years. And then the Families First Prevention Act, which is really going to, I think, make a difference in this part of Virginia. You know, I recall so many families who came in, or kids that came in with grandparents or uncles or aunts taking care of them because of opioids, because of methamphetamine. What the Families First Prevention Act does is it actually has funding for mental health, for substance abuse, for housing, for food, for some of the other services that families need so their kids might not go into foster care. So big change in things, and how this funding will be administered will be important, but it's good to actually have that. The Pandemic and All Hazards Preparedness Act was funded as well too, and this actually makes planning for disasters a proactive activity rather than a reactive activity. So it's looking out and saying, you know, unfortunately there is going to be a next Katrina, a next Irma, a next Maria, and how do we have the funding in here so that our families are able to get what they need? And then some of the things that we know are important, because health insurance is great for our families, but if they don't have food and if they don't have a place to live and they don't have other income, it really is hard for them. And it's hard for us as pediatricians as well too. So important that these were some of the things that were funded. So some of the challenges, the AAP is supporting our chapters in terms of some of the Medicaid waivers that are out there. And this is particularly interesting for Virginia. So Virginia has not had a Medicaid expansion population, but there is talk about doing that in this state, and that this will actually include a waiver, a work waiver from the beginning, which, you know, in my estimation, it's better than not having it. And I think what's happening in Virginia that's really, really pretty nice is that the discussions about what does work mean and who qualifies for that work waiver is going to be important. So in Virginia, if you're a young parent taking care of kids under 5 years of age and staying at home, that's going to be counted as work. If you're somebody, because it's work, I mean, you're not getting paid for it, but it's work. If you are an adult who is caring for an ill relative, or you're a parent who's caring for a child who's medically complex, that's going to be considered work as well too. So these people who don't have incomes will be eligible for Medicaid if that goes through. So that's a really important distinction and something that the Academy has been advocating that happens in other states as well too. Immigration, one of those non-controversial topics. So immigration is one of the statistics that I found really incredible from the National Immigration Law Center is that 1 in 3 children in this country live in a family of mixed immigration status. Now that could mean a parent with a green card, it could mean a parent with a work visa, it could mean a sibling who has DACA, it could mean an undocumented relative. But what's happening in this country is that with some of the ICE raids that are happening, families are scared. And I don't know if you're seeing this in practice or not yet. I'm certainly seeing it. I mean, we're seeing families who don't want to bring their kids in when they're sick because they're afraid that somebody's going to come and report them to ICE. We have kids that are coming in who are having chronic stomach aches and headaches and other anxiety issues because they're afraid they're going to get home and their parents aren't going to be there. And because of that, this has become a pediatric issue. So what the Academy is advocating is that we don't separate kids and parents, that we have safe places for families to be and to stay, and that we really take a big look at this and look at who are our criminals, who are our real felons, and how do we take the terror away from all of our families, because this is really promoting toxic stress in our kids. And we don't need a generation of kids that are not going to be able to function at the level that they should be functioning. So it's important to really talk about this with kids. Now, I separate that issue because this is the issue we see day to day. This is not a border issue. This is a what we see in practice issue because of the families that our kids come from, and that 1 in 3 kids are from a mixed immigration status family. The border is a real different situation, and I was just down there a couple of weeks ago, and that's actually pretty harrowing. The thing that is so bothersome about the border is that there's a whole industry built around hunting immigrants, capturing immigrants, processing them, deporting them, keeping them in detention centers, and then the Office of Refugee Resettlement has these shelters for the kids. They separate parents and kids at the border. That's a routine thing that happens. And then these kids who are undocumented minors are in these shelters, which are very child-friendly, except you don't have your parent there. And when they go in front of the immigration judge, beforehand they're given a piece of paper in English with a list of pro bono attorneys that they can contact. And we're talking 3- and 4-year-olds. Yeah, I mean, it's horrifying. Fortunately, we do have ProBar, which is part of the American Bar Association, helping out these kids. But we really are doing a huge injustice, and I think that where the Academy is coming in, we're just telling it like it is, saying this is happening. Are we better than this as a country? We should be. You know, and in the face of all of the issues, again, we have to bring it down to kids and families because that's what we do. They are our patients. They're the reason why we're here. So a couple other things happening. So the AAP is actually in a lawsuit against the Food and Drug Administration over cigarette warning labels and then the whole topic of e-cigarettes and vaping. And the problem is that many of these vaping products are actually now owned by Big Tobacco, and they have a huge social media campaign. You ought to see my Twitter feed. They come after me all the time, but that's okay. I don't mind. I call them the vaping vipers because their whole thing is that vaping is way more safer than cigarette smoking is. And, you know, first of all, we know that that's not necessarily true because right now we don't know. I mean, our lungs were not designed to inhale particles, and these are all particles. And so, you know, what does formaldehyde and polyethylene glycol and things like that do to your lungs? We don't know yet. And so the FDA has not been doing what it needs to do in terms of regulating the age and regulating the flavors. And actually yesterday there was actually some advancement on this in that the FDA is going to be cracking down on e-cigarette sales to minors. So we're going to be looking at 21 as an age where you can get this. Really important because there's an interesting phenomenon known as juuling. Has anyone seen a Juul? Those little things that look like flash drives that kids are like puffing in between classes, and you can like take your sleeve and puff it. And what's happening is that we have a whole new generation getting addicted to nicotine again. And these are some of the devices where that's happening. I worked a lot with our State Tobacco Settlement Foundation, which is now the Virginia Foundation for Healthy Youth in Virginia. In 1999, when the Master Tobacco Settlement came out, I think 28% of our high school kids were smoking. And we got that down to 11% in 2015, and it's beginning to go back up again. And the reason is this, is that nicotine is so addictive, and adolescent brains love addiction. So they're really primed to be addicted. And so if you're an adolescent and you're starting in with nicotine in any of these products, you are becoming addicted. And the way that nicotine is delivered in these e-cigarette and vaping items is a little different than smoking. So you've all seen a smoker take a drag of a cigarette and just relax. And what happens is the nicotine level goes way up and they feel satisfied. With e-cigarettes and these vaping devices, you have to keep puffing, and you get little bits of nicotine that come into your system. So if you're a teenager and you're getting addicted to nicotine, and that little bits of what you're getting from e-cigarettes isn't doing it for you anymore, what do you start doing? You start smoking. So about a third of our kids who have been using Juuls and vaping and e-cigarettes are becoming smokers. So that's one of the reasons that we really need to crack down on this. And so this is a partial reward. You know, our feedback to the FDA was really a strengths-based Bright Futures approach. We were appreciative of what you did. How about those flavors? So when you're marketing things in gummy bear and cotton candy and French toast, you're not marketing to adults. Who are you marketing to? So, and really, truly, what kind of self-respecting Marlboro man is going to trade in his smokes for gummy bear flavored e-cigarettes? So as you know, I'm not real subtle with talking to people about things, so that was actually the question that I had to the FDA commissioner. And so flavors are really going to be the next battle in all of this. Marijuana. So fortunately, not something coming through, but something a lot of our families are demanding in this state. It has been an issue in other states. Again, the developing brain for pediatrics is of great concern for us. The safety of edibles. There have been, particularly in states that have legalized marijuana, there's been a huge increase of kids going to the pediatric emergency department with overdoses because, you know, who doesn't want to eat gummy bears if you're a 2-year-old, whether they have THC in them or not? Vaping and smoking, it's estimated about 10% of kids who vape actually vape marijuana daily. Have you seen much cannabinoid hyperemesis syndrome here? Oh my gosh, we are seeing that all over the country, and I'm hearing from our pediatricians about this. This happens to daily users of marijuana, and it's a syndrome where there's severe abdominal pain and vomiting to the point of dehydration. It does not happen with everybody who does daily marijuana use, and what we know is that if you stop daily marijuana use, it goes away. But and that heat tends to help it. But you know, this is a marijuana-induced problem, and it's something that we're seeing in great numbers, and you know, not a good effect. So medical use. So does marijuana help out seizure disorders? You know, there's a lot of hype about cannabinoid oil, but research just isn't there, and it's evolving. But you know, from the Academy standpoint, we're fine with decriminalization. We're real wary about legalization. So let's talk a little bit about addressing violence against children as a non-communicable disease. So we just started this Gun Safety and Injury Prevention Research Institute, and this was announced back about a month ago at our annual leadership forum. And again, this is such a politically divisive topic that it's really important to bring it back around to kids. And, you know, I had the fortune of working here for 5 years and talking to families, and what I learned is that I never asked if they had guns in the home, because they all did. I asked, how do you keep your kids safe? And the feedback I got from families was great. They were like, you know, I'm really glad you asked me that, because now when my child goes to his friend's house, I'm going to ask how he keeps them safe. And I may have told you about this, the one interaction that I had with a patient here that just really framed this in that we've got to be working on gun safety with our families. So I had a little guy who had been seen in the emergency department because he drank an unknown amount of cough syrup, and he was fine. But I just reinforced where you keep your medicines and keeping safety locks on them and keeping away from kids. And the dad looked at me and he said, well, you know, Doc, we keep our medicines on top of the gun rack. He had to climb the gun rack to get to the cough syrup. And, you know, so I'm thinking, okay, where do I start? But it really illustrates the fact that so many of our parents are gun owners. They love their kids. They don't want unintentional injuries. They don't want homicides. They don't want suicides. And can we coalesce around gun safety? And so that's really where the Academy is coming in. It's just really important to say, how do we keep our kids safe here? And the fact of the matter is that the research is really not there in a lot of things. So this is just a slide looking at the diseases, number of cases, and number of NIH awards. And you can see a little bit of the discrepancy there. And this was because of the Dickey Amendment in 1996 that really disallowed gun injury research. And so this is really being re-examined on both sides of the aisle in Congress right now, because even some of the things that are really just about gun safety we don't know about. Let me give you an example. Trigger locks. There are places that give out trigger locks. Who uses them? How do they use them? Does anybody use them? Does it make a gun safer in the home? We don't know. Gun storage and safety locks, again, you know, how are they used? How are they distributed? Do people use them? And that's really some of the research and evidence base that needs to happen, because when you look at your different states and your different gun laws, it's very, very heterogeneous. You know, some of the other research is, how do we talk to a family who lives in, say, Massachusetts or New York about gun safety versus somebody who lives in Virginia or West Virginia? It's going to be very, very different, and we really need some research around that. So what the Academy is going to be doing in the next few months is bringing together a group of gun safety researchers, doing a summit, looking at what we know in terms of our best evidence with gun safety, and what are the gaps? Where are the gaps that we need to have this here? Since the CDC right now isn't funding it, how do we get partners to do that? And at the Academy, we actually put our foot in the ring and said, we're going to put $500,000 into doing this, Friends of Children. And so far, the response from other foundations have been, let's join you in doing it. Nobody wanted to take the lead, so we took the lead. But other people are joining us and helping out with the funding. The other thing that's really interesting is that we used this as our topic at our legislative conference this year, which was April 8th through 10th. And so on April 10th, we had 380 pediatricians throughout the country going and speaking with their senators and with their congressmen about gun safety. And again, really focusing on safety, looking at and asking about CDC funding. And very interestingly, the feedback from both sides of the aisle, with few exceptions, is that the idea that the CDC needs to fund gun safety research is something that people can coalesce around. So that's a big sea change. I mean, to be able to start there with the research is going to be something that's going to be important, and we see that as a win for our kids, a win for all of us who know that kids live in unsafe environments at home, and really want to do the best for our kids. So that really is something that's important and going to be happening here. If you look at what would a public health approach to gun violence look like, that there's often the comparison to automobile safety or drug safety, and again, these are things that make a lot of sense. It would be great to actually be able to say we've got evidence that banning sales under age 21 is going to help to keep our kids safe. But this is actually moving into another emerging leading edge topic that I'm hearing from all of our pediatricians, and that's in the area of adolescent suicides. So we're beginning to see a rash of kids who are victims of suicide, and it's a different group of kids. We're still in the same kids, but we're also beginning to see now a group of kids who are high achieving who are becoming victims of suicide. And these are like your star athletes and star students. And if you can buy a gun and it's not checked that day, I mean, students' brains are pretty impulsive, and that something that is a temporary setback becomes something that really is enlarged in the minds of our adolescents. And so we have a lot of kids who are using guns and firearms to become victims of suicide, and that's something else that needs to be studied. That's another different topic that we really are looking and beginning to understand. The other piece of adolescent suicide is the social media influence with that. Because what happened 10 to 15 years ago is that you're the star baseball player and you flubbed up a game, and you're disappointed and you're sad, and your coach can talk to you, and your friends can talk to you, and your parents can talk to you. What happens now is that that same person is posting something in the social media realm, And social media does not encourage us to be particularly compassionate or thoughtful. And so they're getting, yeah, you're a loser, and it really is becoming more isolating. So how do we really bring people back in and away from that isolation? Really, really important topic with this. So pediatric voices and advocacy, really important that your voice be heard and that your voice is going to be heard in lots of ways. So advocacy is, it can be talking to a legislator, but really it's what you look at and do and see for your patients and what you're able to do for your patients day to day that's most important. So there are some things that you can do with the Academy that are helpful. The federaladvocacy.aap.org site is a great site for signing up and becoming what's called a key contact. And for your key contact, you can actually get weekly emails going through what's happening in Congress, what might be happening in your state. So it's something if you want to keep up with, it's really a good thing to be able to do. Before I had this job, I was a key contact, and there were some weeks where I just deleted it because you're just busy. But some weeks, if you're interested in looking at a particular bill or a particular topic, it's something that you can follow, and you can follow what you're interested in. So great place to start. Advocacy, though, is a lot of it is really what you do with your patients and what you do within the state. So if you're a member of the Virginia chapter of the American Academy of Pediatrics, great group to really start out with. Residents and young faculty, if you are interested in an advocacy issue, connecting with the Virginia chapter is really going to be the best thing that you can do because they do resident advocacy days. They do, you have some guidance in terms of what actually is happening in Virginia. And you can use your voice, what our state hears from you with your patients, whether it's on gun safety or whether it's on immigrant families or whether it's on food insecurity or whether it's on insurance. It matters because you have the contact with the kids and with the families. And residents, don't look past your ability to be that voice as well, too. It's just as important for you. Medical students, same thing. So I'm going to move on to our 5-year strategic plan at the Academy. A couple of things that we are really focused on here. I've talked a little bit about addressing bias and discrimination, both with our immigrant populations, but also within our own way of looking and dealing with things. And then physician health and wellness is an important topic as well, too. And we actually have done some surveys at the Academy. The PLACES survey is looking at pediatricians who graduated in 2002 and 2010 and following along with this. And what we're finding is that people love pediatrics. They love the kids, but they're getting burnt out. And burnout is coming from administrative duties, workflow efficiency, feeling like for pediatricians is very much feeling like you're not doing for your patients what you need to be able to do for your patients. So the Academy is looking at addressing that. One of the ways that we've done this nationally is through the National Academy of Medicine, which is the collaborative on clinician well-being and resilience. And this has included members of some of our other societies, but also the American Hospital Association, who is a really important partner because if you think about it, where is your RVU, you have to do these many RVUs coming from? It's the hospital. It is, we don't have the resources for this. It's the hospital. It's much of the stress that's coming from hospitals as big businesses, and you have to understand that they are businesses, but what can we do to actually help this out and make things better? So, as I look at this and what we do with advancing child health through the practice of pediatrics, the idea that we could be looking at team-based care, non-traditional medical home team partners, and technology, I think, is important. And the idea is how do you begin to take some of the things that are out there being done well and put them into the day-to-day operations of pediatrics. So team-based care, how do you take a nurse in your office and have them really work with a set of children who may be medically complex or socially complex? This is one big thing a lot of practices and institutions are beginning to do. They're beginning to hire MAs who are also working as scribes. And so the group that they're getting this from is often people who are finishing college and they've got that, they want to take a gap year between college and medical school, and they're working as medical assistants and then sitting down after rooming the patient and working as a scribe. And at the end of the day, you are editing charts and you're not sitting for 2 hours doing charts. Putting in a social worker to work with a family, or a behavioral health facilitator, or an asthma case manager. So who are some of the people that can help you out with some of the needs that you know your families have, and work as a team, and work importantly for the best of the patient? Because what a well-trained office can actually detect are things like overwhelmed new parents, food insecurity, domestic violence. And if you think about our Maslow's hierarchy of needs, our families come in and we want to talk to them about their child who's obese, and they're thinking, I'm getting evicted from my apartment today. And they're not there. And so what could we be doing to be looking at screening and addressing basic human needs, safety, belonging, and then working on achieving potential and how that translates to your child? And the potential collaborations are really important, and advancing child health is in many ways helping to have better connections with the partners who are out there, really doing some co-location and having ways that we can address some of these issues in our practices or in the hospital. So could we do this to drive our social history screening? This is actually something that was done at Cincinnati Children's when I was there, and it was actually a very smart thing. So we had questions for everybody every time they came in on benefits, housing, depression, domestic violence. And generally what happened is people just took like a pen and went, whoop, you know, they don't have any of those. But if they identified them, we were able to connect them to some resources. And one of the big resources that we found had to do with formula at the end of the day. So in our questioning with our parents, we found that about 50% of our families didn't make it through the month with their formula supply. And we found that the kids were on WIC, and WIC is supposed to be supplemental, but for a lot of these families, WIC is it. They don't have a supplemental on there. And so what they were doing instead was watering down formula. They were using cow's milk. They were, you know, doing all kinds of other things. And so, you know, kids would wind up anemic, and we found it was a problem. And so Cincinnati actually did a study on this. It was called Keeping Infants Nourished and Developing. And what they did was they actually gave out formula and tracked it, and tracked some of the outcomes for these families. And one of the things that we found was that addressing a basic human need, first of all, helped us connect with those families, which is what we do best as pediatricians, but helped us connect in an important way. And so we were actually able to, the kids in the program, find parental depression, housing issues, benefit issues, domestic violence at a statistically significant higher rate than we did if we didn't address this. The other thing we did is look at the number of well visits completed in the first 14 months, almost double. And this is because we gave out formula. I mean, this is just looking at food. And this, and again, you know, if we think about the whole big aspect of pharma, you know, we don't want to, we want to be on the side of our patients, but is there a difference between giving out medications and giving out food? And I think that's the question that we have to ask about here. Behavioral health and primary care. So some offices actually are co-locating counselors and behavioral health therapists in the office. Home visiting. One of the best resources you have is CHIP of the Roanoke Valley here. And to be able to do some sort of co-location so that you can connect your families and then be able to have home visiting is important, because I look at this as preventive mental health. You know, we talk about the whole realm of mental health, but what we're really good at as pediatricians is prevention. And preventive mental health is all about making a parent feel like they know what they're doing with a child, reinforcing safety in the home, teaching about normal developmental milestones and what happens when you have those milestones where you're going to be butting heads with your child, and how to do effective discipline that's going to build brains. So it's an important part of the whole integrating behavioral health and primary care. There's an element of home visiting. It's a group called Healthy Steps that a lot of the home visiting programs are actually beginning to just take this over now. And what they're doing is, in addition to the home visiting piece, they are co-locating somebody in primary care and in some cases subspecialty offices. And why subspecialty offices? Because that's where you see a lot of the kids with special health care needs. So if you're a pulmonologist or a cardiologist or GI, you're often going to see your NICU grads, you're going to see your kids who have had the most trouble with eating and the most trouble with other things. And so to have somebody to come and talk about, with that family about what are some of the developmental things that are happening with your child and how do you handle them, and that your frustration is actually normal, it's a normal part of parenting, and your 2-month-old doesn't hate you because they're crying, really important. So to be able to, it's sad that people think that. I mean, you know that. We know these things. And so having somebody co-locate from home visiting to be able to do that enhanced developmental counseling in between appointments or while you're waiting for the doctor or while you're waiting to have labs done is something that's happening across the country. And again, that's something that really helps. This is my zip lining picture, so I've been going different places across the country and across the world and looking to see what pediatricians are doing to advance child health at the level of the practice. So a couple of cool things that have happened. So this is a group from Buffalo, New York. They actually were able to get Medicaid managed care to pay the salary of a therapist to co-locate in some of their private offices. An idea to be doing with our Virginia Premiers and others of this world. They also were able to get funding from them and get them to actually have a quality coordinator. So if you look at quality metrics, that takes a lot of time and a lot of staff time that really isn't, it really isn't something that we've applauded, but they've been able to get Medicaid staff to do this because if Medicaid wants their HEDIS measures increased, why not put that on their shoulders to get them in there? Value-based payments, so there are places in the country where they're paying a dollar per member per month for all of the sick visits. And what we found in a couple of places through the country is that it was super low. It was like $7 per member per month. And we were able to work with practices and negotiate an increase based on the fact that they're open access, that they've got extended hours, and that they're able to really make ends meet by doing this as opposed to having these kids go to the emergency department. Asthma care management, to be able to have that as something that's part of your practice and have Medicaid paid for. So this is a practice in Houston, Texas, and they started an asthma care management program for their nurses. And we met and actually had a big opening and had Texas Children's Health Plan come in there. And they are now paying a per member per month for the kids who are getting asthma case management. And we talked to them about behavioral health. They said, in Buffalo, they're actually paying the salary of a therapist to come in there. And Texas Children's is starting to do that. And South Carolina is starting to do that too. So what we're doing is taking good ideas, meeting with folks locally, and saying, okay, how can we actually do something in your community that's going to be better? So telehealth. Telehealth is another big topic because it has the potential to do a lot to extend the medical home. Of course, in the first iterations, what we see is the fractioning of the medical home. So we see teledocs or some of these places that you can call up at 3 o'clock in the morning and you can have your child diagnosed with something that's going to require amoxicillin, regardless of what their symptoms are and without a physical exam. And that's not where we are with the Academy on this. So some of the things that we're supporting is a study on supporting research outcomes and utilization of telehealth. And the SPROUT program has 70-plus institutions looking at best practices for telehealth at all levels. So a children's hospital mentoring a community hospital, a children's hospital emergency department mentoring a sick child in a rural community hospital, a pediatric cardiologist talking with a primary care physician who may be in the community, or being able to, through a Bluetooth stethoscope, listen to a child's heart, or a pediatric behavioral health therapist to be able to come into an office through telehealth, or a primary care practice who's using telehealth as part of their triage. So looking to see what are these best practices and how are things beginning to get done. Project ECHO is another topic. That's the extension for community healthcare outcomes. This is a project that was started in New Mexico and was all about adults with hepatitis C. It's been expanded. The Academy actually is taking a lead role in this in pediatrics. And the programs in ECHO are both a collaborative where there's a didactic piece to this, but then there's some one-on-one mentoring. So you could have some mentorship with somebody who knows about Zika or knows about environmental health conditions or behavioral health. And then therapy by telehealth. So we're looking at some of the better groups out there for affinity programs and resources. So there's a couple of neat things happening here. There's a group called .com Therapy, and what they do is speech therapy by telehealth. And this actually was studied. They looked at a cohort of kids who needed expressive speech therapy. And we looked at the Medicaid population because these are the kids that are less likely to actually make it to their appointments. And they had 30 speech therapy sessions via telehealth in the home and found that, first of all, patients made it to their appointments. But secondly, because you don't put a 2-year-old in front of a tablet or a computer on their own, there was a caretaker there who was listening in to what was going on and learning the skills. And so a lot of these kids actually made it to their goals earlier than with face-to-face therapy. So, you know, there's some evidence that using this for therapy may be something that may be helpful. But this is the problem with telehealth, is payment. What are you getting paid for? Would you get paid if you were a primary care practice for reaching out and doing triage? I mean, it may be a great thing because you might prevent somebody with a diaper rash from going to the emergency room. You would be able to tell the difference between a sick child with a temperature of 102 and a well child with a temperature of 102. I remember one of my mentors telling me, you know, if a child has a fever, you got to see them right away or else they might get well. So, and you know, we know this. So but if you think about it, if you can actually lay eyes on a child and see that they're not tachypnic, that they're running around and playing with their temperature of 102, your advice is going to be very different than with a sick child. But how does that get paid for? How does it in places like Roanoke, Virginia, where we have patients coming from West Virginia and Kentucky and Tennessee, crossing state lines and licensure? So this is all of the work that the section on telehealth is working on. How do we actually make this happen? And if any of you come down to the Orlando meeting this year, PEDS 21 is the 21st century topics the day before. It's going to be entirely on telehealth. And it's going to be very different than what the PEDS 21s have been like. They've been primarily lecture-based. This is going to have a little lecture and a lot of demonstrations. So you can actually see telehealth software. You can actually try to see what it's like to see something virtually. If you've never used a Bluetooth stethoscope or an otoscope, you can see how that is. So it's really going to be kind of exciting to see what technology could do to advance the practice of pediatrics. So the National Conference and Exhibitions late this year is November 2 through 6 in Orlando. I think we have some people coming down here from Corellia this year, but should be pretty exciting and a lot of good resources for all of us. So back to addressing bias and discrimination, one of the things that we know about our pediatric residency graduates is that more than half of them are going into subspecialties. I think that's a great trend because we need that subspecialty expertise. But at the academy level, the academy has been very primary care based. And so how do we work on diversifying our board and our leadership? Because the intellectual property and capacity of our members in our subspecialties really is what drives our policy and what eventually drives our practice. So we're diversifying our board. We're actually adding 3 new spots, one specifically for a medical subspecialist, one specifically for a surgical subspecialist, and then one for an at-large member. And I think that's really important, again, to be looking at how do we embrace all of our pediatricians who are here. Our aspirational project coming up here is a Child Health Clinical Data Registry. This was also something that we decided we needed to start doing. A lot of medical societies have data registries. We don't, and really the idea that we're able to begin to now collect some of the data on where are our immunization rates with kids, if you have Medicaid, what services you get versus not having Medicaid. Surprisingly, what you find is that sometimes your kids who have private insurance get less help because there's some economies of scale in Medicaid. And what is this going to do? So we have an incubator group that is now getting together and looking at how should we collect this data, how should we de-identify it, what are some of the things that we could be doing that are very 21st century to de-identify this, things like even iris scans on some of our babies to have that as a de-identifier. So that's to come, but we're beginning to get started with this. The new building is up and running now in Itasca, Illinois. It's a beautiful place, but what's really nice about the building is the capacity for video conferencing and virtual interaction. Because again, we know that our pediatricians are often too busy to come and spend a weekend in Elk Grove Village or Itasca or Illinois, but you might want to have your voice heard. And to be able to be part of a writing committee or to be able to be part of a policy committee or a section leadership and to be able to come into a meeting for a couple of hours via a very robust telehealth virtual connection is important. And so we're going to be employing more and more of that to be able to get more and more of our members involved. And then finally, the website. This has been actually one of my biggest criticisms of the Academy for years is that their well, try it now. It's better. It doesn't suck as much as it used to. So that's, no, it's actually much, much better now. So there's been a real initiative on digital transformation. And this is the first page of what you get to on the website now. So you can find your policies right away. You can find healthychildren.org right away. You can actually search in the search function, and it's better than Google. So things are really happening there. And the next iteration of this is going to be on our mobile devices. So and having that robust as well, too, because there are times when you're on rounds and you'd like to actually see what the policy might be on antibiotics in a certain situation or, best way to treat bronchiolitis or, any topic. If you can pull it up online, it's a great way to be able to do that. And the Academy needed to better connect our resources to that. So with that, I'm going to finish the formal presentation and ask for questions. And again, thank you so much for inviting me back here. It's great to see how the residency is developed. It's great to see everybody is doing, and I miss you. Thank you.
Dr. Kraft, thank you so much for a wonderful overview of the Academy's work and what you're doing to help pediatricians across the entire nation. I have one question, though, about how we actually implement some things. Since 1 in 2 patients in Virginia actually come from Medicaid in our area, and trying to have them fund things in a state in which the strategy has been to underfund Medicaid, what are some strategies that perhaps the Academy has thought of to help states in which this is the actual climate?
So good question. So the question is about Medicaid and how do you get them on board to do the right thing for their patients? So it really is, when you look at Medicaid, it's all run by managed care. So we have to start looking at some local partnerships. Now at the Academy level, at the big Academy level, we used to have a Medicaid strategy and a private payer strategy. It's now just become the same because Medicaid is being run by private payers now. So it is looking at the local level and at the state level and starting to have those meetings with Virginia Premier and with health keepers and with your other medical directors and folks. The best way to start to do that would be to contact Amy Siebert, who's one of our Academy staff who does legislative advocacy, and start with getting those meetings together. And in the places where I've started and have done this before, we've looked at specific things. The pain points for Medicaid are behavioral health, and that was one of the things that started this off. So Medicaid managed care would prefer that you refer your 3-year-old with behavioral health problems and get them into therapy as opposed to writing a Risperdal prescription for them. And that's where we had to say, okay, where is it and how do you get them there? And when you give a parent a phone number, you give them a barrier. And that doing things the way that they're going to do them is not going to work. And that's how the group in Buffalo were able to make the case that maybe having them fund the salary, so we don't have to worry about payment, et cetera, but fund the salary for doing this. And then let's see how many of your patients are able to get that behavioral health therapy and meet that HEDIS metric and maybe not have the cost of some of the antipsychotic meds. So, but that's where you have to get started and talk about that and find one project that you can do together.
Colleen, it's always good to see you. I don't think it is. It's on. Yeah. So whenever I hear a presentation from the AP, and probably this is just the nature of the beast, I hear increasing government dependency, not trying to make people more independent. And what programs or efforts does the AP have to decrease that dependency?
So good question. I mean, I think probably the best thing that you've got is Bright Futures and beginning to really work with that family in terms of their own goals. And with work being one of those goals, the other thing is that co-location with home visiting. I mean, one of the big things that CHIP does is it gets families out of that whole, welfare piece into working. And it's something that's got to happen at a local level, but it's something that you and I can't do as pediatricians. We've got to really depend and co-locate with our partners to advance that piece of child health. So it's really tough. It's some of it is working with things like the Medicaid waivers, and if you need to work to get a waiver, that's okay, except for the people that really can't because of circumstances where they're taking care of kids and family members. But I think that it's promoting the relationship we have to encourage families to move beyond, and then some of the services for families that will help that out. Anyway.
Thanks, Colleen, for the talk. And your joke lines are one of the things I forgot that I missed about you. So, I had a question, but I also now have two related to Don, so I'm sorry. Comment. Has anyone looked at the generational effects in a real research study for provision of these social health programs that in the short term seem to increase the government dependence role, but what does that do for the kids? Does the next generation of kids who hasn't grown up hungry, who hasn't grown up with housing insecurity and food insecurity, without quite so much toxic stress, does that lift them? Does that make a difference? And I wonder if the AAP could look at that really long-term outcome.
So some of that is the reason behind the data registry, to be able to look at that long-term for those kids, but also for kids that that grow up in families where people are working and, that don't have abject poverty around them, and what does that do there? So that's one of the reasons for the registry. There are some really good studies that are beginning to look at exactly what you're talking about with long-term toxic stress and what you're able to do to support. And I think that's where a lot of the academy policy has come from. So I mean, Council on Community Pediatrics would have some good resources on that. Even doing a search on studies in that realm would probably be able to show you what's going on.
One would hope that maybe if we can't help this generation, we can help next,
right,
which is our patients. My real comment and question was two slides that you had really struck me. One was a 40% depression rate among physicians, and wondering how it really intersects with that burnout issue. I'm now the mid-generation pediatrician, and I've got a lot of young pediatricians that work with me, and, our toxic stress is, okay, I do social determinant of health screening. I'm supposed to. I've got food banks that I can give patients the information about that are open 2 hours a month on a Thursday, mid-afternoon. I have very little I can do if I get that information, and that creates
and your patient doesn't have transportation. So I mean,
and your patient doesn't have transportation.
Mm-hmm.
So that creates a level of toxic stress for us.
Mm-hmm.
That's one of the reasons pediatricians don't screen.
Mm-hmm.
It's too
Absolutely.
hard to know and not do anything.
Right. And that's why if you're going to do screening, you need to start with something that you've got an answer for. And then how are you going to operationalize that connection? Very much like the question with Medicaid. You know, I mean, it's identify one thing that you can be working on together that's going to be a win-win for both of you, and track that. And I think that's some of what the community roundtable afterwards is going to be about. What's one thing that we could do to try to move the ball forward? But if you don't screen for the other things right now, that's okay. I mean, it's better than not doing anything at all.
So just a comment, Amy, about studies. The Ramies actually have done those studies generationally up for 40 years and looked at intervention in very early childhood for both food and for educational intervention, and it makes a generational difference, and I think that's why people have been able to fund for so very long early intervention programs. To speak to your point about interacting with our local managed care providers for Medicaid, we have looked at taking their the top spend for patients here in the Commonwealth, and working for a managed care aspect to their care, which has been relatively good. For the top spend dollars in Virginia are for hemophilia patients, actually.
Right.
And so being able to actually speak to the medical director quarterly about how we do the spends for them and getting in different cares for physical therapy that they will pay for, home care that they will pay for, has been useful because it's such a high spend for them. The part that they don't want to engage in are the things that are not costing them so much money.
The bottom 80% is 16% of the cost.
Exactly, which we have to incur as pediatricians and as health systems to be able to provide that care without getting 32 cents on the dollar for what it is that for the care that we give.
All right, so we are over time.
Okay.
But we have the roundtable afterwards. So if anyone needs to go, now's your chance, and we'll continue the discussions. We'll leave the lines open. Don't forget to sign your book in the back for Dr. Kraft as a thank you for coming.
And
but,
thank you.
If anyone needs to go,
coming.
now's your chance, and keep the. Okay. Do you want? Can you stay? Okay. All right.
Okay, we're ready for the roundtable discussion.
Ready for the roundtable discussion?
So this is really informal. It's not a formal thing at all. I'm interested in hearing what's going on with you, and you know, what I can do is let you know what things are happening in other communities, and you know, just feel free to go on from there. Carly, how are you doing? Good to see you. So it's good to see everyone here. So.
Does anyone have any questions?
Oh, Amy does.
I would love to learn more about the co-location experience that you have with maybe food banks and primary care.
Okay, so that was, we started, the experience I have with that was with Cincinnati. And they started with what they called, they're keeping infants nourished and developing. And started really just with formula. And what they did that was a little bit different than what's been happening is they had labels and kept a log of who formula was given to. And then they looked to monitor along with who it was given to, what else were they first of all able to screen for, what were they able to connect to, and what visits did people make. So it was interesting. So that I think that the first place I would start with that, if you did that, would be looking at tracking your well visits and tracking your immunization rates. You could be tracking things like emergency department visits as well, too, with that. And, you know, start there and look at what are some of the other things that addressing a very basic need might help out with. Now, with the food banks, some of the other things that were helpful with co-location were once the formula was something that was happening, then the question was fruits and vegetables. And so one of the things that they were able to do that I think wouldn't be too hard to do was a program with the local farmers markets. Because I know that they already do twice EBT here for the farmers markets, but what could you do to have a kiosk on site at clinic? Because even though, you know, clinic is not that far away from the farmers market, it is for you. I mean, it's where you're out in Daleville, it's tough, but could you actually have a farmers market kiosk out there? Or even, you know, day-old or other vegetables and fruits that could just even be given away for families. That was the second thing. But what you have to do is you have to start with one thing at a time. You know, if your first thing is formula and beginning to track what else happens when you give out formula, that's a start. And then you can go from there into what your next thing may be. Yeah.
So, Colleen, first of all, thanks so much for coming, and it was a great Grand Rounds. I was going to make a comment at the end of Grand Rounds. This relates directly to the food bank issue, and thank you so much for referencing Child and Health Investment Partnership of Roanoke Valley, CHIP, which is celebrating its 30th year this year of service to the community. One thing that you don't know, you mentioned MeChiv, which is a great home visiting program, but CHIP actually lost that funding, so we're no longer part of that. But one of the things that we've started a couple of months ago is a series of what we're calling community conversations. And we have brought together like-minded organizations around our community, and the biggest thing that rose to the top was the whole issue of food and the trouble that people have accessing food banks, and the fact that banks are open limited hours. If we do have working parents, it's hard for them to get there, and travel is an issue. So we actually are putting together a resource that will become available to anyone who wants it. Some point in the future, we're trying to hire an intern who will actually work on this, of putting together all the local resources, finding out where food is available at what times, and also looking at other areas where we might be able to provide food and especially have it available off hours, whether directly in, and no one has thought about primary care physician offices. So that's something I'll definitely bring back. I'm president of the board of CHIP finishing this year. So I think, you know, bringing in a representative from our primary care community would be a great idea, and you know, we'd definitely be happy to continue that work.
That's great. I mean, and you know, as much as can be physically present, so you know, we found that kiosks are a great thing to be able to have, you know, non-perishable stuff there and available for families, and you know, and then the other thing that, and this is something I really picked up at Cincinnati, was that it's great to have it there, but track it. You know, see what information you can find from it.
One of the things coming to mind as you're talking about having a kiosk there and ability to give out fruits and vegetables is a hurdle that my family has been aware of. We're involved in a food bank in our home community, and my father at 82 has over an acre of vegetable garden, and they donate all summer long. But they found that families didn't know how to prepare the vegetables and weren't taking them. And so particularly when it's something that might not be your average broccoli at the grocery store, that you need to also have ways of teaching families how to prepare the food so that it will be appealing, because it's not in a frozen bag with directions on the side.
Right, right.
Or can.
So the groups that we've been able to get involved in that, two groups. One of them are the grocery stores. A lot of times the grocery stores will have people on hand and are willing to even come to an office and show that, but to be able to have public places to do it. Schools are a good place to do that too. And the other one are restaurants. So one of the things that happened, this actually happened in Richmond, was that some of the local restaurants get together usually once a quarter, and they have kind of an open house. Here's how you prepare some of these meals. And it's really for people who have not grown up cooking and don't know about cooking. And you know, what you'll find is that that's throughout the whole socioeconomic status. It's really important for our families living in poverty, but it's important for other people as well, too. And so, you know, to begin to maybe put on a program where you have a couple of restaurants doing some demonstrations there might be a neat thing.
One comment that I had was to kind of speak to what Alice was saying. We have implemented, starting in July, all 4 of our pediatric offices within Carilion Children's started participating in the iScreen project through the AAP. And so we started to implement developmental screenings, MChats more regularly, and then the maternal depression screening, as well as the hunger vital signs that was implemented in February. We got some significant we got some significant pressure about not having resources when we got a positive hunger vital signs. So what I had, we had Ruby, one of our residents, take a zip code dot map of all of our patients and what counties they live in. And she worked tirelessly identifying all the grocery stores within each county, all the gas stations that accept EBT cards, and kind of put them on a map and put them in a spreadsheet so we have access to not only grocery stores and gas stations, but also food pantries, what their hours are, where their location is. And we have those available to us in each one of our clinics and available if we have a positive screen to provide to our families.
And that's a great thing that was done. I mean, and that's really your approach to a lot of these things, or what is it that you are able to do? So, yeah.
Hi, I'm Sheila Umber. I'm the director of the city libraries.
Okay.
The reason I'm here, we do a feeding program through the library with Feeding America,
right,
and also with the YMCA. I think that you're spot on with talking about classes, but I would also encourage anyone in the community to consider the library as a neutral community place for this type of work. And again, I think I love the idea of formula and all of that. We haven't thought about infants, but one of our partners in our program called Star City Reads, we have 28 community partners working on reading and literacy for children. But one of the things in the campaign for grade level reading is health initiative, and particularly asthma, dental health, as well as nutrition and brain development. So again, I guess what I'm putting out here is we're here because we think this is a wonderful idea, and I think as a community we would put out that libraries are also a place where people go, and we're open late at night sometimes.
Well, and wouldn't it be great if you had a family that knew they could get formula at the library and they started going to the library instead of, you know, watching TV at home? That would be a wonderful thing. It would be a great outcome even. So, you know, it almost seems like if you were able to start with one thing and you had multi-sites that were available for people to reach those to access, even starting with infant formula. Start there and then look to see what does that mean for the number of books that are checked out, or the number of hours are spent in the library, or, you know, and it would be all processed right now, but families going to the library would be a big change from what is happening now in a lot of places. So I think that would be a great thing.
Well, I would ask the group, or, you know, we came in for the roundtable, I would ask the group if we wanted to start that here in Roanoke, who would be the most obvious partner for us to talk with about that, adding that to the feeding, because we are creating the pantries with Feeding America right now at we have 7 locations that are right in the middle of the neighborhoods. So we have a lot of people that walk to the library.
And Sheila and Amber, being completely modest, I wanted them to come today because they've been a huge resource for me with Reach Out and Read. So we've kind of known each other for a while, but
they provide lunches during the summer to kids.
That I know. I remember that.
Yes.
So.
But then they're doing a big book drive, and they collaborative with another group where they serve breakfast on Saturdays, and there's breakfast with books. So they're a tremendous resource, and so I thought it was really great for them to come today.
I'm really glad you came, yeah.
So there's a lot of collaboration between our local library systems on books. Okay, my Botetourt, I can go to the Fincastle Library and I can order books from wherever for my kids. Have you looked at partnering further out, outside of Roanoke City, on the food and feeding programs? I guarantee I've got a lot of families in Troutville, in Buchanan, in Eagle Rock who could really use these services, and that's my patient group as a primary care physician. And it's a great program. I'm not belittling what you do at all. I think I'm asking you to expand.
Well, weirdly, you're asking the right person because they hired me to convert the card catalog to computer code about 30 years ago, and I was involved in making the uniform library card for the Valley. So, yes, we actually have a consortium meeting tomorrow. I would say that we did add, Roanoke County, we added Vinton, as well as the swimming pools to our program last year. So since we started, we have fed 17,000 meals to children in the summertime.
So I was on an email thread about how basically all of our clinics stopped giving formulas, and we stopped having them, and there was an issue possibly with the NICU patient not being able to have formula. And so I was contacted by someone at a church, basically, or at the health department, saying that we could maybe house them in the churches, and that way the patients would be able to pick them up if they couldn't get to WIC in time or whatever the case was. So that's another possibility, too.
Only as physicians and children, we're holding a little bit for the GI office is right next to us as well.
Right, yeah, and the GI office is making formulas, too.
Yeah. So that's the barrier. That's going someplace.
That's the new policy that just passed.
No, I know, but work around the barrier.
Right.
So I work, down at near River Valley, and we have a ton of patients. Well, it's kind of split between like affluent people and then people who rely on WIC, and they get their WIC appointment after the baby's born, and it's a month later. And I've called myself as a physician and said this child needs to be in sooner because we only have so much that we can give them, and we can give them some samples, but we're paying for that, so the hospital won't. Right. We have to feed all of the babies that possibly need formula. Have y'all found anything, because I'm fairly new out there, I know it's a different setting, but have y'all found anything that we can get them in sooner, or we can get them formula samples, because these parents, or vouchers or something, these parents are saying, like, I had one family that said, I have to ask my mom if she can pay my power bill so I can buy a can of formula to last me to my WIC appointment. And aside from me paying these poor families that verbalize it, I don't know what to do.
You wonder if you could actually even have somebody co-locate in the hospital. I mean, that would be, it would be so efficient to be able to sign up for all of that at the same time. I mean, it would just make sense to be able to do that for the babies. So would that be Montgomery County WIC? Yeah, that's true. That's true. Right. Mhm. Mhm.
So it covers a ton.
So it may be, what I would do is I would try to start with one and see if there's at least a day a week that somebody could co-locate up there. But I think that's something that, again, at the state chapter level, to be able to make the connection with the state WIC department, and bring that to let them know that that's really a problem, and what could we do to maybe begin to look at fixing that. So I will send you Virginia chapter AAP resources, because that would be where I would start going in through there. So So I do have a connection with the Vaccines for Children immunization, the immunization registry at the state level, because it's now run by my son. So he's so he's the data manager for VIAS. So so if you have any problems with that, I can actually, I've got a direct line in there, but that's right.
So is everyone who gives vaccines putting stuff in now, like urgent cares to pharmacies? I know pharmacies are.
They are. So pharmacies are, and what's happening is it's beginning to be tied to the birth certificate now. So they are beginning to get it from all kinds of different sources. So, so I'll have to ask him about urgent cares that are not part of hospital systems. So urgent cares that are part of hospital systems, they should be getting that data in there.
It would be helpful if everyone who gives vaccines is required to put it in the VIS system.
Right.
That needs to happen.
Well, I know what they're working on is really just being able to automatically export that data. So rather than somebody having to input that, exactly. And they're looking at newborn hearing screen and newborn metabolic screen to go into that as well too.
And you can access.
So, okay, so hearing is actually already up. So I know he's been working on that. So yeah, newborn screen. I mean, the metabolic screen would be great.
Loading over. Oh, I'm loud.
But there's people at home that can't hear you on the phone.
I know the pharmacies aren't rolling over at this point, but most of them, we've been pretty lucky where they'll fax us like they'd be given the vaccine, so it can potentially be loaded on site.
So really one of the other next things he's working on is trying to bring the ordering of vaccines into the 21st century, because I know it's all paper right now, and he's disgusted with that. So he's working on that piece of it now. So so it's funny. He's a computer science physics major, and he was always a fan of Paul Offit's. And when the job came up, he sat me down one day and he said, "Tell me everything you know about vaccines." And so I did, and he applied and he got the job. And he said, "You know, people had better resumes than mine, but I knew about vaccines." So.
This is sort of back to your topic before. I just wanted to say I work with Community Health and Outreach through Carilion, and we're partnering directly with the New River Health District to do our community health assessment, and also this summer to be putting together an implementation strategy to look at how we're addressing need together, public health need in the community. So we should touch base afterwards, and maybe at least on a local level we could start a conversation and see what's possible. And also I love that you had a list. Sorry, jumping way back. I love that you have a list of all the grocery stores and everything that take EBT. Also, you mentioned earlier, one of the things that Carilion funds in the community is an EBT SNAP match at some of our local farmers markets. And so they actually get double value for their money if they go to some of these farmers markets. So that would be something that we'd love to touch base and make sure that that gets added on the list.
So what is your name and how do people contact you? Because I think you would really be one of those ombudsman, coordinating point people to help doing some of the connecting pieces. Because again, these guys are seeing patients all day. So it's, what you can do to really help out with the connection would be great.
Absolutely. Well, my name's Amy Michaels. I work in Community Health and Outreach, and actually we have an entire team of health educators who are going out doing different types of health education. A good portion of it is focused on adults, but we also are the office that's running the Safe Kids education as well as the Infant Safe Sleep education, where parents can come in and access some of that information, as well as oftentimes get free pack and plays and sleep stacks and things like that. So that's another good resource that's available. But our Community Health and Outreach, I can help, our Erin Bush, our manager. These are different. We coordinate a lot with our local foods. In 2015, lack of access to nutrient-dense diets was the top need that came up in the Roanoke Valley on our needs assessment. And poor nutrition really comes up in a variety of ways in all of our communities as one of the top needs. And as nonprofit hospitals, every 3 years we have to put together a strategy that talks about what Carilion's going to do in partnership with our community to try to address some of those needs. And actually this summer is the time when we're putting that together. So it's the perfect time to kind of have some discussions and write in whether or not there's some strategies we can employ to try to address some of these needs going forward for the next 3 years.
That's great. That's great. You need to bring Sheila into it. And
Sheila's actually helping with the community health assessment.
Donna? She's another one.
Okay.
Sure, Kara.
So as much as I love food, I have a somewhat off-topic but personal kind of question about how to address this, and probably Erica has some insight. Children with chronic diseases, I don't feel like we transition to adulthood well at all as pediatricians. Even when I tried to address it on a very chronic inpatient child when she was 16, or I think she had just turned 17, many of the rest of my colleagues, I kind of didn't get on board because it was so far off, and it might be, until she had to transition to adults, and she was a year away. And to me, I feel like we need to be having that conversation earlier, and there's a lot of research about that. But what resources or research or information is the AAP doing to address this? Because this is just my perception as a patient. I still think adult doctors look at me as a child with a child disease, and I'm 32. I was put in the PZD when I thought I was in DKA because I had type 1, and so they said it was a child's disease. Like, we need to address that these children with CF and type 1 diabetes and cerebral palsy are not kids forever. Right. And even as a hospitalist, I get consults sometimes that they're like, well, they're 22, but they have cerebral palsy and they have all of a seizure disorder and all of these pediatric diagnoses. Can you come and help us? So have we partnered with adult colleagues because they need to
So a couple of things. There's a program out there that's called Got Transitions that it's been HRSA funded, but the AAP has been a part of it. That is really kind of that toolkit and really addressing how do you think about transition when you're 14 and you're not 18. But the real lack has been the adult providers who are willing to take care of these patients. And it's very much like how, if you think about how pediatrics was with behavioral health 10 years ago, and where some pediatricians still are now, where they're just not going to address it. I mean, that's where our adult community is. So we actually are working at a national level with the American College of Physicians and the American Academy of Family Physicians on how do we do that transition curriculum and begin to, very much like when you were in residency, you did 2 months of child psychiatry. When I was in residency, there wasn't even close to anything that we did. But how do you start getting into training? If you're going to be in family medicine, part of your pediatric training needs to be with kids with chronic disease because you should be expecting to see them and manage them when you get in. And same thing with internal medicine. And that needs to actually be part of their residency training program. So that's some of what's happening with ACP and AAFP. And again, that's one of those things that at a local level, you have to start looking at building your own coalition and connecting our adult colleagues to some of their actual resources within their own academies. But we're talking about the national level because it's so important. And, we're not seeing these patients die anymore. They're becoming adults, and we need, exactly. Yeah, that's right. And so we need the capacity to be able to care for these people in a very respectful and dignified way, and physicians who know how to do that. So, yeah. So, right, and you'll see. Yeah, you'll see some of the subspecialties taking this on. So I know that there are some adult CF clinics. I know that there are some adult congenital heart disease programs. But what you don't see are the chronic metabolic diseases. You don't see a lot of the neurology stuff. That's not happening at all. And where a child with cerebral palsy is generally managed by a pediatrician with some help from neurology, in the adult world, they have no idea what to do with that. So that's where some of the national resources are helping. How that's filtering down to residency training is really going to be important. And then how we engage our local colleagues to do that is going to be important too. So one other thing I'm going to mention, just because this has been something that's been showing up on the national stage as well too, and I actually think Carilion does this better than most people, than most places I've been to, And that's the idea that there are some hospital systems that are no longer hiring physicians and are only hiring advanced practice practitioners for positions. And there's some of them. So there was a hospital outside Vail, Colorado, that let go of all of their pediatricians, hospitalists, and they're bringing in all nurse practitioners who are connected with Colorado Children's Hospital. That's happening. And I've been very, very vocal about this and working with NAPNAP, and NAPNAP has come out and said, we are not interchangeable. We're a team. We need to be working together as a team. I don't want to be in charge of a whole floor of hospitalist patients as a nurse practitioner. That was not what I was trained to do. And so what I'm really pushing the Academy to do, and this is our seniors, our CAO and leadership, is to get a joint policy statement out there saying that we are not interchangeable. We have a team-based care policy statement out there, but it doesn't hit the point of, you know, it's that we need to really be working together, that these are not substitutes. Because a lot of hospitals are just looking at the bottom line and saying, well, gee, you know, an NP, a PA is less expensive. And, you know, and this is not to put down our partners, our advanced practice partners. They're wonderful. We need them. We work well with them. But we need to work in a team-based care situation and not a substitute for each other.
Do we have any more questions or any questions on the line?
I do know that Virginia just passed their independent nurse practitioner, yes. Mm-hmm. Yeah, that got through the legislature.
Yeah.
So,
one thing, Rob Gard, as far as insurances, I mean, from primary care, we've been battling prior authorizations for various things, and just this year we've seen a rash from what seems to be Virginia Premier, Medicaid products, just flat-out refusal for different things from therapies. For example, if a child has a diagnosis of cerebral palsy and the code will say unspecified CP or nonspecific CP, there seems that there's just more and more trends of denial when there's no really other diagnosis out there, just to deny it, just to see if we're going to stop having them get therapy,
which is horrible.
Which is horrible. And just from a national level, what's the AAP doing with
some
of these
national
trends?
level, that's where taking over what used to be the private payer advocacy. It's now just payer advocacy, because we know that Medicaid in many states is being run by managed care. And so it's looking to see who are those connections at the national level. Here's our policy. How do we get this to filter down to the states to find the things that are happening and to battle that. But that's something we're getting involved in the state chapter is going to be important too, because at the state level we've got the connections with the managed care organizations and really with the legislature to say, okay, this is something where we've got to really sit down with you, Virginia Premier, and talk about what kids need, what we're able, what's evidence-based and what's science-based and what should be covered.
It's unmuted, so okay. All right. I guess. Go ahead and wrap it up.
Yeah.
Okay. Well, thank you all for joining us.
And thanks. I'm really interested in hearing what happens with food insecurity and your partnerships here, because